box in the footer of today's meeting. So please feel free to leave your questions in the Q&A box in the footer of the screen, and at 10:50 we will be answering these questions. Dr. Walid will be thankfully answering these questions received. So thanks again for your attention, and thanks for attending today's meeting. And Dr. Walid, please, the floor is yours.
Good evening, everybody. Ramadan Mubarak for all of you. Let me thank the organizing company for this webinar. And we'll go through some good ideas about treating the residual risk of cardiovascular disease. And everybody knows that when we handle the any disease, we go through primordial things by doing healthy behavior, eating good diet, do regular exercise, and quit smoking, do physical activities. And then we move to risk factors modification in the primary prevention setting by treating dyslipidemia, controlling the high blood pressure, treating diabetes, and treating metabolic syndrome. However, when we reach the atherosclerotic cardiovascular disease, and when the patient has coronary heart disease or cerebrovascular disease and peripheral disease, peripheral vascular disease or heart failure, now we are reaching the secondary prevention, and that's the range that we handle the disease. Over the past few years, the idea of high triglyceride, whether it's causing atherosclerotic cardiovascular disease or not, has been going in and out, and we were handling like a seesaw, and everybody was talking, is it the high triglyceride or the low HDL? Because we know that once the triglyceride go high and the HDL goes low. And we did learn in the mid-80s and early 90s that high triglyceride are a really risk factor for cardiovascular disease. But at that time, when they adjusted the risk factor for the HDL, they said, well, no, the HDL, the low HDL is the problem, it's not the high triglyceride. And then the idea came out. But we were adjusting for the same disease, and that's why we did not get the idea that triglyceride increase the risk of atherosclerotic cardiovascular disease. Now we tried to treat low HDL by giving a lot of medication, and everybody knows that whether niacin or other medication that used to treat low HDL did not show any benefit in the cardiovascular. So the low HDL is a bystander and probably just an innocent marker. However, the triglyceride, there is now a lot of studies, whether it is epidemiological study or genetic study, or now interventional study by treating high triglyceride, that we are reducing the risk of cardiovascular disease. Just let me mention one study. This study from University of Cambridge that studied the genetic basis for the production of the apoprotein B. We know apoprotein B is present in both LDL and VLDL. And if we have the genetic that block down synthesis of those two things, the apoprotein, which is incorporated in LDL and VLDL, will get significant reduction in cardiovascular disease. However, if we get the genetic that the genetics that block the production only for LDL, we get some milder reduction in cardiovascular disease. And the same thing, if we get the genetics that reduce the production of lipoprotein lipase, which is affect the metabolism of triglyceride, will get minor reduction. So if we get a reduction of both of them, we'll get significant reduction in cardiovascular disease. So with that, there is some residual we know that we treat the LDL, we reduce the cardiovascular disease, and we reduce the incidence of the complication. But we still, the patient, even if we control the LDL, they still have residual risk, and we need to target this residual risk. And one of these targets are treating triglyceride. And there is a lot of medication to treat triglyceride. Everybody knows that fibrate may reduce the triglyceride, niacin may reduce the triglyceride. However, it does reduce only the number, and it doesn't reflect the incidence or the complication of cardiovascular disease. It doesn't reduce myocardial infarction, it doesn't reduce mortality. So all those studies were negative with niacin and fibrate. The idea of omega-3 came by, and some studies were a little bit positive, the other negative, and the other were neutral. But however, we know that triglyceride is a risk factor for atherosclerotic cardiovascular disease. And I'm not going to go through the details, but we know triglyceride comes from the guts, and it is and absorbed in the form of chylomicron, and in the liver it's turned into remnant and VLDL, and then it is the triglyceride can enter the intima of the vasculature and may cause atherosclerosis. Now, this is the meta-analysis of omega-3. This is the meta-analysis of more than 23 studies that were conducted over the past 20 years. And you see all the studies did not show significant reduction in cardiovascular disease. And this meta-analysis total is neutral. You see the rate ratio is at 1. So with that, the idea of omega-3 did die. And actually myself in the early at the beginning of this century, I was taking omega-3 because I thought that it is positive. But after those studies, I stopped taking omega-3. But let's go into more detail about those omega-3. And just about 2 years ago, the ASCEND study came, and this was a good study and published in the New England Journal of Medicine, and studied the effect of giving omega-3 in the diabetic patient. And this this is the ASCEND study, and was conducted at the University of Oxford and presented at the ESC in Munich back in 2018. And this is the result. This is a randomized study between placebo and omega-3 fatty acid in diabetic patient, whether to see whether this medication can reduce the cardiovascular event. And this is the placebo, and this is the omega-3. And you see those curves are superimposable on each other. So it is a negative study, and it did not show. However, if we go into subgroup analysis, and just remember, in a study which is neutral, or what we call it negative, you can go through subgroup analysis. But just to get an idea, you see through this subgroup analysis, only the vascular death was decreased and was statistically significant. Again, we cannot depend on the result because the primary results were neutral. But it is hypothetic generating idea that maybe the omega-3 fatty acid may reduce some kind of cardiovascular event. The other big study is the VITAL study, and this also gave the omega-3 fatty acid compared to placebo for a longer period, exceeding 5 years. And you see the curve at the beginning, at the first 2 years, the curve are on top of each other. However, after 2 years, the curves start to separate, showing that maybe there may be a benefit from the omega-3 fatty acid later. And again, if we go into more subgroup analysis, we see after the 2 years, if we exclude the event after the 2 years, the total myocardial infarction was reduced by omega-3 compared to placebo. And this was statistically significant. Again, we cannot depend on this subgroup analysis since the primary endpoint were no, neutral. But just this is hypothesis generation idea to continue on conducting research to use this medication. Now let's talk about those medication omega-3. A lot of people know that all the omega-3 are coming from the fish oil and they are the same. Just in this study, 80% of the pharmacists and 80% of the doctors who are recommending taking fish oil supplement, they think that this is an FDA approved. No, this is an over-the-counter and it's not FDA approved for anything, for any indication. And again, 30% of the pharmacists and 22% of the doctor believe that this supplement has similar strengths and content. No, it's not similar in content. Again, because of that, a lot of people and a lot of doctors are giving those prescription for whatever available over the counter for fish oil or omega-3 to reduce the atherosclerotic cardiovascular disease, especially in diabetic. And if we conduct a survey about the patient and ask them whether they're taking fish oil or not, you see that almost 20% of the patients are taking fish oil or omega-3, thinking that they have some benefit from the cardiovascular, reducing the atherosclerotic cardiovascular disease. But they are totally different supplement. So one of the basic scientists at Harvard in Boston, his name is Relay Mason, he conducted the chemical evaluation of one of the major available over-the-counter omega-3 fatty acid. And according to him, that this major, I'm not going to mention the name because we are not talking about any, we are not talking against any product, but one of the major and commonly prescribed over-the-counter omega-3 fatty acid preparation has only 21% of EPA, and we'll come with EPA stand for eicosapentaenoic acid, and only 9% has DHA, but the remaining components in this tablets, 36% saturated fat and 34% other fat, and those fats are really may be harmful and may get oxidized and turned into oxidized fatty acid and may enter the intima and cause some damage and be pro-atherogenic. So when we say omega-3 fatty acids, that's remind me when I was a medical student, they said gonadal hormone, and we know gonadal hormone include testosterone, estrogen, and progesterone, and they are considered gonadal hormone, but the effect of those three kinds totally different. And now we know that it's totally different. A lot of omega-3 fatty acid, but they are totally different. Just you can change the property by adding an oxygen or adding the double bound. So we need to concentrate more on the chemical components of those fatty acids. So we'll talk about the first one, which is icosapentaethyl, which stands for IPA. That's the product which is present in one of the purified preparation, and this is prescription medication by Amran. And this is when it is entered into the gut. It got really hydrolyzed by the lipase inside the gut and turned into eicosapentaenoic acid. So IPA and EPA, they are the same, but it's not exactly the same. It's one is a preparation medication, and the other one is turned inside the gut. Now this kind of omega-3 fatty acid enter the gut and go into the circulation. So the other kind is the DHA, which is common also, and is dihydroxypentonic acid. And they are totally different, but they are the most common kind of omega-3 fatty acid available in the preparation. So let's go into more details about their effect. The APA generate what we call a resolvin, called e-resolvin, and that's affect the cell membrane and make the cell membrane more stable. Compared to that, DHA generate a different kind of resolving called D. The EPA decrease oxidation of apoprotein B, and that's mean reducing the atherogenesis compared to the DHA. DHA doesn't affect that. The EPA also decrease the cell membrane fluidity, so prevent entering the glucose inside the cell, so prevent the action of pro-atherogenic cholesterol, compared to DHA, which increase the cell membrane fluidity and will be pro-atherogenic. And this is a study comparing the DHA. Look at this curve in blue, and EPA in red. The effect on oxidized LDL, we know DHA now increase the level of oxidized LDL. And also DHA may increase the level of LDL itself and may increase the level of VLDL compared to EPA, which are neutral and may reduce all those bad substances on the intima of the vasculature. And if we go more into more details, really on the cell membrane, look at this EPA, which is get well organized through the cell membrane in organized fashion, compared to DHA, which get in chaotic way and get flex through the cell membrane, and that's may increase the membrane fluidity, increase the accumulation of LDL, and may increase the oxidation of LDL, compared to EPA, which preserve the membrane structure and make normal distribution of the cholesterol, inhibit oxidation of the cholesterol, and may influence the signal transduction pathway that affecting inflammation and increase vasodilation. So now what we learned now from all that thing, that supplement low dose EPA DHA does not reduce cardiovascular disease, and even intermediate dose does not reduce cardiovascular disease. And now recently, a high dose of EPA with combination with DHA does not reduce cardiovascular disease. And I think everybody remember just last November at the American Heart Association, the strength study, which used high doses of EPA combined with DHA, and the results are neutral. No difference between the combination omega-3 and the corn oil, which is the placebo. So it does, this combination doesn't affect the cardiovascular outcome because of this contradiction between EPA and DHA. So we need to concentrate and really the product which is EPA, and get that as a purified substance and reach in a medium or high dose, so to see that effect. And we'll go through those steps. This is the GILAS study. The GILAS study is a conducted study. A study was conducted in Japan early at the beginning of this century, and used a medium dose of EPA purified, and the dose was 1.8 gram a day. And just even with that, compared to the control, we got significant reduction. It's not it's a moderate reduction. It's around 19 to 20% in cardiovascular event, and whether the cohort was through primary prevention or secondary prevention. So this is the GILAS study, and I hope everybody reviewed this study, and this was published in the Lancet back in 2007. But there are some criticism about that study. And one criticism is that it is conducted in the Japanese population, which could be totally different from the other population, whether in the Middle East or in the Western country. This is number one. Number two, for criticizing this, that they used low or intermediate doses of statin. At that time, they reported using simvastatin of 10 milligram, which is a low to intermediate dose. But remember, in 2007, the idea of using high dose statin was not there at that time. So this is another criticism. And the other criticism, although this is a randomized study, but it is an open label, and there is no placebo counterpart. There is only the control. So, and if you go into details, especially if you are thinking the American way, some people refuse to consider any study which doesn't have placebo in the arm. But however, this is a well-conducted study and a randomized study showing reduction in cardiovascular events, even if we use low dose or low to intermediate dose of this purified EPA. And another study from Japan did the same way, the same thing, that the same dose using 1.2 gram a day of EPA on top of statin, which was pitavastatin 4 milligram. That's adequate dose of pitavastatin. And they did IVOS, intravascular ultrasound, before and 6 to 8 months after receiving the therapy. And there were significant data showing that there is a plaque regression. So this is a mechanistic study explaining that the reason that we are reducing the cardiovascular event is probably due to plaque regression and plaque stabilization. A third study from Japan conducted on 241 patients, the same way, intermediate dose of EPA 1.2 gram a day, and on top of pitavastatin, and that showed a reduction in cardiovascular event, and not just in cumulative or combined cardiovascular event. There were reduction in total mortality, and the total mortality rate was 0.8 with the active medication versus 4.2% for the control, and the p-value was significant. But however, this is a small study on 241 patients, and you cannot get the idea that this medication reduces mortality. We need a larger study, but it is a hypothetic generating idea. I did mention the effect on the membrane, so we're not going to go again. But the idea, I don't want anyone to get the idea that DHA is a bad substance. It is a good substance, especially in the infant and then a neonate. It's important for the production of the neurons. So, but at least I think in the other population, the EPA is the way to go for a beneficial cardiovascular event. I did mention about the membrane stabilizing, but just we need to remember also the EPA block the free radical oxidation, so prevent formation of oxidized LDL, and that doesn't occur in any other lipid or triglyceride lowering medication. It doesn't occur with fenofibrate. It doesn't occur with gemfibrozol. It doesn't occur with niacin. So now, shall we give fish oil? Now, we remember that if we get penicillin from penicillin mold, and we get paclitaxel from Pacific, and we get icosapent ethyl from marine fish. So shall we tell the patient to eat just fish? I don't think that's enough, because that means we need to eat a lot of fish, and is not purified. So this is not the way. The way is to take purified medication, and this is the way. The pure EPA icosapent ethyl clinical program, that it is a purified medication, and in high dose. And it was studied in 3 stages. The first stage was conducted in people with very high triglyceride more than 500 and less than 2,000. And those the people who have high triglyceride and they are at risk for acute pancreatitis. No, and this study called the Marine study only in 229 patients, and there were no baseline LDL. And it did show that it does this medication reduce the reduce the level of triglyceride and reduce the risk of acute pancreatitis. The other one is the Anchor study, which studied the people with intermediate level of triglyceride, more than 200, but less than 500, and their LDL was between 40 and 100 milligram. And it did show also that it does reduce the level of triglyceride, but it's a small study, only 700 patients, so we cannot conduct uh, uh, um, any information about cardiovascular events. So the big study was the reduced. This is a big study on more than 8,000 patients and was conducted back in 2018 and presented at that time. This is people with mixed dyslipidemia, and the level of triglyceride is between 150 to 500, and the level of LDL always should be less than 100. So on top of statin and well-controlled lipid profile, well-controlled LDL, the LDL always should be less than 100. They conducted this study, and this is the flow of study. There were lead-in statin stabilization. The patient, if he's eligible, they came in and given statin, and for a few weeks to make sure that they reach the lipid and the LDL below 100. And after that, they were randomized to a high dose of EPA, 4 gram a day. That's 2 gram in the morning, 2 gram in the evening. And the other part of randomization was the placebo. And the placebo here was the mineral oil, because it was difficult to give them a simple oil like olive oil. They needed this placebo which match the EPA in the odor, it's match in the color. So they picked up this mineral oil at the placebo arm. And the entry criteria, the patients were above 100 and above 45 years old with established cardiovascular disease, that the secondary prevention group, or a patient with diabetes and more than one risk factor, that's the primary prevention group. And the triglyceride was between 150 to 500. However, they allowed really some around 30% fluctuation in the level of triglycerides. So some people really were having triglyceride to start with around 135. They followed those patients for a period of 5 years and up to 6 years, but the medium time of follow-up was 5 years. This is the baseline characteristic. You see the average age 64-year-old, and females around 30%. Secondary prevention cohort around 70%. Primary prevention 30%. People with previous coronary disease around 60%. Previous cerebrovascular disease 15%, and people with previous peripheral vascular disease around 10%. And as I told you, the LDL, the mean LDL in those population was 74. That's mean well-controlled LDL. All of them had LDL below 100. And the mean level of level of baseline triglyceride was 217, which is maybe for some physician, they may consider that as a normal, close to normal, and other patients just for low-fat diet, and they don't ask them to take any medication. But this is their baseline. What are their baseline medical therapy? The they were well-treated patients. Just remember, those patients are a stable patient. We are not talking about patient with acute coronary syndrome or post-myocardial infarction. Those are stable patients with some primary prevention or secondary prevention. 80% were taking antiplatelet, and 60% were taking only one antiplatelet. Around 10% were taking anticoagulant. ACE inhibitor were present for more than 77%, beta blocker more than 70%, and statin, all of them were taking statin. This is 99.7. So we are checking the effect of this drug on top of adequate dose of statin. All of them taking statin, and all of them, their LDL is below 100. And now, what did we get as a biomarker effect? We did expect that we will reduce the triglyceride, but just remember, the triglyceride did go down, but it did not go that significantly. It's around 20% reduction, and the LDL went down a little bit. The CRP went down significantly, and that may explain that this medication may affect inflammation, and that. But the most important thing, that the level of EPA in the blood, we started with a level of 26, and it went up to 144. That 360% increase from baseline. So this is the most important marker that we got from the effect of this medication, and we can relate that to the result of the study. And this is the primary endpoint. The primary endpoint include the cardiovascular death, myocardial infarction, stroke, coronary vascularization, and unstable angina. And we got significant reduction, 25% reduction in the incidence of this all event, and the absolute risk reduction around 5%. So the number needed to treat only 20 patients. We treat 20 patients, and we get reduction of at least one cardiovascular event, and the p-value is significant. Look at this. How I cannot count those zeros after the point. And the secondary endpoint were really the hard endpoint, whether cardiovascular death, MI, and stroke. And again, more than 25%. It was 26.5% reduction, and absolute risk reduction around 4%. Now, if we go through subgroup, all the subgroup were did get the benefit, whether the patient is young or old, male or female, primary prevention, secondary prevention, taking ACE inhibitor, not taking ACE inhibitor, whether it was treated on the in the US side or the other side of the Atlantic, all of them got the benefit. But just I'll focus on one subgroup. This is the baseline triglyceride. If the patient had baseline triglyceride more than 150, they did get the benefit and was statistically significant. Again, if the patient baseline triglyceride was less than 150, I just remember I did mention that they allowed some around 10% fluctuation. So there were some patients with a triglyceride below than 150. That's mean normal. And even with this normal, they did get the benefit, and it was statistically significant. So the effect of this medication, not just by reducing triglyceride, the benefit of this medication may be explained by other things, because even the people with normal triglyceride to start with did get the benefit. Now we'll go to a pre-specified hierarchical testing. So with that significant reduction in total event, they went through step by step. So we did mention that 25% reduction in primary composite, and I put them in green. We got 26% in secondary composite, with cardiovascular death, 25%, fatal and non-fatal MI, 31% reduction, urgent revascularization, 35%, cardiovascular death, 20%, hospitalization for unstable angina, 32%, fatal and non-fatal stroke, 28%, and um, uh, total mortality and combined with non-fatal myocardial infarction, 23%. And if we take total mortality by itself, also it was reduced, and it was reduced by 13%, and the p-value at that was 0.09, just at the borderline. And I think if we had they continued that trial for another 1 year, this p-value will be significant. But I think the companies decided to stop this study at 6 years because of a financial problem. Amgen is a small company, so they did not want to follow up for more than 5 years. Now let's talk about tertiary endpoints. And the most important thing, cardiovascular arrest, we got 50% reduction in cardiovascular arrest and 31 reduction in sudden cardiac death. So those are two important thing to affect mortality and get significant reduction in cardiovascular arrest and sudden cardiac death. And cardiac arrhythmia were on neutral effect. Now, the effect on revascularization, all kinds of revascularization were reduced, whether it's coronary revascularization, emergent revascularization, urgent revascularization, elective revascularization. So this is, I think, the first study that showing that we are reducing the revascularization, whether bypass surgery or coronary PCI by using this medication. And we haven't heard about any drug that cause this effect after statin. You know, the statin, the first study, the 4S study, was published back in 1994, and that showed the reduction in revascularization. So since 1994 till 2018, we waited for 24 years to reach this another medication that reduce coronary revascularization. Now, what are the side effects? There were no side effects compared to placebo. They were similar. All the side effects were similar between placebo and icosapent ethyl. So this is a medication that is well tolerated. There were some emergent adverse events, and the most important one was increase in some bleeding. And this is the increase of the bleeding was 2.7% compared to 2.1% in the placebo, and the p-value was 0.06. Again, borderline p-value, but if we continue, probably it will be statistically significant. But just keep in mind, although there is increase of bleeding, the gastrointestinal bleeding did not increase, the central nervous system bleeding or the hemorrhagic stroke did not increase. So although it may increase the bleeding, and we'll come to that, but it is a safer bleeding. There is no GI bleeding, or there is no intracranial bleeding. And the other thing which came as really a disappointment, they noticed the increased incidence of the atrial fibrillation, 3.1% compared to 2.1% in the placebo arm, and the p-value was significant. So there were increased incidence of atrial fibrillation or atrial flutter. However, remember that the incidence of stroke totally was not increased. However, we did decrease the incidence of stroke. So although the patient did develop atrial fibrillation, and we know the most dangerous sequelae of atrial fibrillation is stroke, and we did not get increase of stroke. So this medication is safe and prevents stroke, although there may be increased incidence of atrial fibrillation. Again, there is an important point that I have to mention, that whether the patient did reach on this medication triglyceride level of less than 50 or more than 50. You know, you give the medication, some people may get their triglyceride come to less than 50, but the other continue to have a little bit elevated high triglyceride. And look at the curve. This is the red curve for the placebo, and the blue curve is for the people who reached triglyceride more than 50, and the green curve who reached triglyceride less than 150. And you see the green and the blue are on top of each other, whether for the primary prevention or the secondary prevention. That's another explanation that the medication doesn't, the effect of this beneficial effect of this medication is not just related to lowering triglyceride. It has some other effect. And according to those effects, when this trial was published in the New England Journal of Medicine, there were a very nice accompanying editorial called Fishing for Miracles of EPA. And just remember, this is the New England Journal of Medicine, and this is well-respected journal, and you hardly see this nice title for editorial, but because of really compelling data, they accepted to put this title, Fishing for the Miracle of EPA. And when this trial was presented at the American Heart Association back in 2018, there were a discussant, that's Professor Carl Oringer, and he put this slide that the people who's taking maximum dose of tolerated statin, we can add on top of that ezetimibe, especially if they are in the phase of acute coronary syndrome, and that's according to improved study, or if they have stable atherosclerotic cardiovascular disease but continue to have elevated LDL on top of maximum statin, we can add PCSK9 inhibitor, and everybody knows about the Odyssey and Fourier studies. However, if the patient has atherosclerotic cardiovascular disease with the statin and their triglyceride is around 150 to 490, we can add EPA to reduce the cardiovascular risk. We did mention the primary endpoint, and that's they calculated the time to the first event. But however, the patient may get the first event as a non-fatal MI, and probably a year later may develop another non-fatal MI or non-fatal stroke. So the future events is important, and they did an analysis on the future event. And you see, this is, we know about the result. I did show you that we got a reduction in the first event, 25%. But if we follow to the next event, we get further reduction to 32%. If we follow for the third event, further reduction to 30%. If we go to the fourth event, we'll get more further reduction, 56% reduction. And that means significant reduction after 4 years. And what's the reason for that? We know that when we are taking medication for more than a year, the adherence to the medication goes down. And I did show you that this is a safe medication. There is no significant side effects. So the adherence at first year was 81%. It did come a little bit at the second year to 79.5%. On the third year down to 68%, and the fourth year to 68%. Although we did get drop in adherence, but we did continue at the fourth event to see significant reduction in the events. And look at that curve, that significant reduction at the fourth event, and got 30% reduction. And look at this p-value, that at the subsequent event. So we are not just reducing the first event, we get accumulation of reduction of further event. And look at those curves, that they are separating and getting wider separation, wider and wider. And whether that's, I did show you for the primary endpoint, and this is for the secondary endpoint. Now, so how can we translate that in our clinical practice? For 1,000 patients, if we treat those patients with EPA for 5 years, we are preventing 12 cardiovascular deaths, 42 fatal or non-fatal MI, 14 stroke, 76 coronary revascularization, and 16% hospitalization for unstable angina. That's mean reduction of total of 156 primary composite endpoint. I did not show the slide for that, but also for the further analysis, they got reduction in hospitalization for heart failure. This is a medication also now reducing the hospitalization for heart failure. So this is subsequent analysis, and this was published in 2019, and there were accompanying editorial of this further analysis, and they did tell in this editorial that secondary analysis of reduced provide even more confidence in the importance of the effect of this medication, icosapent ether. Now, again, let's go a little bit further into more details about the tertile of baseline triglyceride. I did tell you that there were some patients with baseline triglyceride, which is close to normal, and they did get the benefit. There were mildly elevated between 190 to 250. They got the benefit. And the people with triglyceride at baseline more than 250 to less than 1400, they get the most benefit. And that's logic. You get more money and more benefit for the high level. Now, there were further analysis, subgroup analysis, whether the patient started with 150 or less than 150, whether they developed a triglyceride level less than 200 after 1 year or after or more than that. Also, those subgroup analysis did show that the benefit. So with that, let's go and remind ourselves about what other medication available for treating hypertriglyceridemia. When I was a fellow, there were the VA HIT study, which did use gemfibrozil at that time and caused the reduction in triglyceride and the reduction in cardiovascular event. But just remember, that's back in 1999. At that time, there were no statin to be that available, and there were no high dose of statins. So this was showing the benefit of reducing triglyceride with gemfibrozil. After that, the field study used fibrate, and the Accord study used fibrate. It did reduce the level of triglyceride, but it did not reduce the cardiovascular event. The niacin, everybody knows the niacin reduced the number of triglyceride, and everybody remember the AIM high study, and it did reduce the number, but no effect on the cardiovascular event. And with the omega-3, now we have the reduced, it does reduce the triglyceride and now reducing the cardiovascular event. And I did mention the GLS. Okay. I'm sorry, I have now some, okay. Now, okay, good. Now, what's the beneficial effect? This medication has some good things on the endothelial layer. It improves endothelial function and increase the bioavailability of nitric oxide. Also on the endothelial layer, it prevents oxidation of the LDL and prevent production of adhesion molecules. That's for the macrophages, and that will prevent the formation of foam cell. On the inflammation level, also it increased the level of EPA compared to the arachidonic acid, and it reduced the production of those bad substances which are intermediates for the inflammation, that are like interleukin 6, ICAM1, interleukin 10, and CRP and metalloproteinase. On the plaque itself, it increased the fibrous thickness of the plaque. That's mean making the plaque more stable and preventing plaque rupture and causing plaque stability. It does reduce the plaque volume and the plaque vulnerability and the plaque thrombosis, and it does reduce platelet activation. Now, what other medication we can see that from the analysis of the reduced study, it did show that this medication also reduced the systolic blood pressure to around 1.3 millimeter, and it did reduce also the diastolic blood pressure to a half millimeter. This study I brought it from my mentor at Harvard, Dr. Peter Libby, and this the effect of omega-3 fatty acid and the production of this inflammation and inflammasome. So this medication, it reduced the inflammation. I did mention that this medication also caused some minor bleeding effect, and probably the effect is through their effect, direct effect on the platelet, preventing platelet aggregation, or on the thrombotic pathway and the coagulation cascade. The direct effect on the plaque, I did mention that, and the oxidation, prevention of the oxidation of the LDL, I did mention that. Now, I have to mention one mechanistic study called the evaporate study. This is the same, similar to the reduced. They randomized the patient to take 4 grams of EPA and placebo, and they studied their coronary vasculature by CT angio before and between 9 to 18 months after taking the medication. And they did show similar things, that the plaque volume and the plaque thickness did get reduced. Now, why did the strength study was negative? I did mention the strength study from the beginning because it did have a combination of EPA and DHA. This combination contradict each other. We are waiting for another study called the prominent study, which are using a different kind of triglyceride lowering, which is called pimifibrate, and this is a PPAR alpha agonist, and the result will be available early next year. So this is the cardiovascular outcome trial. The reduced is positive, strength is neutral, and we are waiting for the prominent. Now, let's finish with summarizing the residual risk. If the patient has cardiovascular risk, she should take high intensity statin to reduce LDL. If he continue to have cholesterol risk and the LDL more than 100, we need to add another medication, and this is statin, and we know from the IMPROVE IT, and there is another new medication, pemphidic acid, that reduce the production of lipid. If the patient has residual inflammatory risk, and we can assess that by CRP level, if the CRP level is elevated, there is medication to reduce that, whether it's canakinumab, which was conducted in the CANTOS study, but recently everybody knew about the result of the Colocott study and using the colchicine to reduce the inflammation, and it did reduce the cardiovascular event. If there is residual thrombotic risk, we can assess that, but there is no biomarker to check that, and we can treat with antithrombotic by giving dual antiplatelet, and everybody heard about the Pegasus using ticagrelor, or the Compass using rivaroxaban, using rivaroxaban. And if there is residual triglyceride risk, that's we go through the reduce it. And if there is elevated lipoprotein little a, we are waiting for more medication to affect this substance. However, this remember that EPA affect a lot of those things. It doesn't affect the triglyceride. It's by itself. It may affect inflammation. It may affect antithrombotic, and may affect LDL. So with that, all the association got the approval to use this medication. This is the American Diabetic Association give that level A to use this medication to treat atherosclerotic cardiovascular disease. And they did mentioned according to the reduced trial, and their recommendation not to use the combination of statin and fibrate. I'm sorry to still see that a lot of patients receiving fibrate and it doesn't affect the cardiovascular. So it is not recommended. And niacin, again, I'm still seeing a lot of patients receiving niacin. It is not recommended. And the European Society of Cardiology with the European Atherosclerotic Society, they did give that level 2A for using this APA for reducing triglyceride level and preventing atherosclerotic cardiovascular event. And the National Lipid Association, I'm not gonna go just now. I started to show you that from the beginning. Now we know that intermediate dose of EPA, purified EPA, as in the GELA study, reduced cardiovascular risk, and high dose of EPA only, as in the reduced study, it reduced cardiovascular deaths. And this is related to the increased level of EPA. So look at the level of EPA in the blood. We started with the GELAS, was at 92 and went up to 120. In the American population, we started with reduced, the level was too low to start with 26 and went up to 144 and 160. Why the strength study was negative? Because it did not bring the EPA level that high. It went up only to 90, and that's why there were no benefit. And with that, this is the pyramid of the cardiovascular risk. Now we are reaching the secondary and tertiary prevention with the reducing the triglyceride level. I think I'll stop here. I'll be happy to take any question.
Thank you a lot, Dr. Walid, and I think we're having a few questions. The first question is regarding the type of patient. He's asking, I would like to know for which patients exactly should use the purified EPA or Vasipa?
Well, the patients who are at risk for the developing atherosclerotic cardiovascular disease, and as I showed you, those are the patients above the age of 45, either they have a history of coronary artery disease or cerebrovascular disease, that's the secondary prevention cohort, or they are primary prevention, they don't have any history of atherosclerotic cardiovascular disease, but they are at risk. And the most important thing is whether having diabetes and an extra risk factor. So diabetes and hypertension, diabetes and smoking. So there are some analysis from the European Society of Cardiology that put the indication and the entry criteria for this reduced according to the general population, and they found around 20 to 25% of the general population are a candidate to receive EPA, whether they are primary prevention cohort or secondary prevention. And just remember, this study was conducted on people who have really well-controlled statin below 100. So once you see your patient, I hardly can see my patient with LDL below the 100 unless they are really good patients. So if you see your patient is LDL more than 100, try to control the LDL and reassess the triglyceride. If the triglyceride is above 150, yeah, they are a candidate to take this purified EPA.
Thank you again, Dr. Walid. And the second question is about what do you think about giving 2 grams per day dosing?
Well, as I told you, the study, GLS study, but this was conducted in Japan, and probably the Japanese people are totally different because they are well known that they have low BMI. They are not fat compared to our people here. So I don't think the dose will be adequate. But we were waiting for more research. If you can uh, check the level of the EPA in their blood at baseline, and if their level of EPA is high, then 2 gram will be adequate, as I showed you on the slide before the last slide. But if the level of the EPA is like the Western population, like the US and European population, and their level is less than 50, I don't think 2 gram will be adequate. And just remember, the Japanese study, they used 2 gram and they got only 19% reduction in cardiovascular event. And now I showed you in the reduced study, they used 4 gram and we got 30% reduction in cardiovascular. So if we need to get more benefit, we need the higher dose.
Thanks a lot, Dr. Walid. And the third question is about asking for more elaboration about the AF incidence in the strength trial.
Yeah, the strength trial also got increased incidence in atrial fibrillation. It's so like the reduced study, they got increased incidence in atrial fibrillation, and that's whether has some effect on the electrolytes or the probably the action potential in the atrium. We don't know. It's just it is a disappointing finding in both trial, and we need to keep on our eye. But remember the safety thing. I did show you in the reduced, although there were a little bit 1% increase in the incidence of atrial fibrillation, but there were no increased risk of stroke. And they did the subgroup analysis, whether the patient had atrial fibrillation to start with, or develop atrial fibrillation during the period of the trial. Those two subgroups did not show increase in the incidence of stroke.
Thanks again, Dr. Walid. And if you have any more questions, please leave it in Q&A section. I think in chat box, we've covered what was in the Q&A box. I'd like to thank you, Dr. Walid, on behalf of Biologics team, and thanks a lot for all the participants in today's meeting. Now you can see the pop-up evaluation form. You can just tick your evaluation regarding the today's webinar. And again, thank you all, and have a nice evening. And thanks again, Dr. Walid, for your insightful and fruitful presentation today. Hopefully, it will go for the good of the cardiovascular community in UAE, and especially in Sharqa. And thanks again for your attention.
Okay, good night, everybody.
Thanks a lot, Dr. Walid.
Okay, take care.